Bismillahirrahmanirrahim. Welcome to the channel. This is in continuation of Quinsy or peritonsillar abscess. In part 1, we discussed the pathophysiology and clinical features of peritonsillar abscess. So today we will talk about the treatment of peritonsillar abscess. The link for the part 1 is there in the description, so you can check it out before going through this video. And you are requested to subscribe the channel as well. As we know, peritonsillar abscess or quincy, these two terms are synonymously used. So when the disease is at catarrhal stage or non-suppurative stage, that is what we call as peritonsillitis. What we expect is the medical treatment. And in the medical treatment, of course, we have to hospitalize our patients, and patient is dehydrated due to rhinophagia and sore throat. So intravenous fluids should be given in ample amount, and intravenous antibiotics, which are covering especially the staphylococcus and streptococcus, that should be infused. And patient is in severe pain, so injectable analgesics may be required, and of course we should go for local mouthwashes for oral hygiene. But once we are suspecting that now the disease has been transformed from peritonsillitis to peritonsillar abscess stage, so general surgical principle that abscess anywhere, we have to go for drainage of that pus. So incision and drainage. So same principle applies here, that is the surgical treatment is situated when abscess formation is there. So, but the important question is that where, how, and with what we have to do the incision and drainage. So, where the place is that the most fluctuating and bulging point of the abscess, that is the area or the site where we should incise it and do the drainage, or we can go for an imaginary line which is horizontal line from the base of the uvula, and then a vertical line along the anterior fascial pillar, where these two lines unite. That can be another point. So in the picture I just describe it, that either you will go on the most bulging point or an horizontal line. I just mentioned this is the uvula, so base of the uvula, this is a horizontal line from base of uvula, and this is the vertical line along the anterior fascial pillar or anterior tonsillar pillar, where these two lines are uniting. Here we can give an incision. So these are the two, you can say, sites where we can think about incising this quincy. It can be done in a sitting position under local anesthesia very easily in the clinic. Usually 11 number knife is used, but with it should be guarded with plastic sticking plaster covering whole blade except leaving the tip of the blade open, so that we should not insert the blade fully inside. Only the tip of the blade should be inserted. Or there are special commercially available quincy knife. As you can see, this is upper one is quincy knife, and here you can see it is obstruction is here. So when we will insert this quincy knife, or we will try to incise the quincy with this knife, only this part, tip of this knife will go in, rest of will not go in, so that we should not endanger the underlying important vascular structures. And once we have incised it, then we have to open the cavity with quincy forceps, or we can use a sinus forceps to open the cavity and drain the pus fully. So as I just mentioned, it can be drained in outdoor clinics under local anesthesia, and so anyone can do it in primary care, but following patients should be referred for the specialist care in tertiary care hospitals. In children severely ill, when difficulty in breathing is there, or bilateral abscesses, though very rare, or a large abscess that obstructs the pharynx and or may extend posteriorly, or unsuccessful drainage in the primary care. So all these patients, they should be referred. Some patients may require IV fluids for hydration, or analgesia prior to this procedure. So we need head light, 10% topical lignocaine in a spray form, tongue depressor, then suction machine should be there, IV line and fluids if necessary, and for aspiration 16 gauge IV needle and 5 or 10 ml syringe can be used, and for incision we need 11 number scalpel blade and angulated forceps. So this is 10% xylocaine spray commercially available, we can use it as a spray. So patient is sitting there on the stool with the head resting back against a headrest, mouth is opened with a tongue depressor, mucosa over the abscess is sprayed with topical anesthesia, that is 10% xylocaine, and then try to localize the pus and insert a large bore needle and aspirate it. So this will confirm the diagnosis of peritonsillar abscess, because if no pus comes on aspiration, it means the patient is still at a stage of peritonsillitis. But if pus comes, the diagnosis of Quinsy or peritonsillar abscess is confirmed, and secondly, the pus has been drained. And if you are sure that whole pus has been drained, nothing further is required. But if you think that still pus is not fully drained, we can go for conventional incision and drainage. So this is the syringe, and these are wide bore needles, and this is how wide bore needle will be adjusted over the syringe, and we can do the aspiration, and these are 2-3 different points we can aspirate to completely evacuate the pus. But if after 24 hours of aspiration still there is collection or the symptoms are not settling down, we have to go for incision and drainage. For incision and drainage, we have, I just as mentioned, there are 2 points, either the most bulging point of the abscess or horizontally from the base of the uvula an imaginary line and a vertical line along the anterior fascial pillar, and where these 2 lines they are crossing, there we have to incise it with the blade number 11 or this peritonsillar knife if it is available. Under guarded knife we give the incision, and then with the sinus forceps we open the cavity and do the suction to remove whole of the pus. Then some people they are in favor of what we call as hot tonsillectomy or abscess tonsillectomy. It means that they say that at the time of quinsy, instead of going for incision and drainage or aspiration, straightforward the patient should be subjected for tonsillectomy. This is what we call as hot tonsillectomy. And mind you, there are 2 different questions. One is hot tonsillectomy, and other question is what are different methods for tonsillectomy, because for different methods of tonsillectomy there are cold methods and there are hot methods. So that question is related with methods of tonsillectomy, but this one is tonsillectomy when actually the pus is there, acute inflammatory process is going on, because for routine tonsillectomy, for repeated recurrent sore throat, that is recurrent tonsillitis, acute infection is a absolute contraindication for tonsillectomy. But here some people are in favor of hot tonsillectomy, but there is danger of that during intubation, due to the Macintosh laryngoscope, the abscess can rupture, and of course acute inflammatory process is going on, so excessive bleeding per-op and post-op, so the complication rate is more high in hot tonsillectomy. So that is the reason that mostly or usually the people are in favor of that, instead of embarking upon for hot tonsillectomy, we should go for conservative management and incision and drainage of the this quinsy, and later on there should be what we call as interval tonsillectomy, and that interval tonsillectomy means that after 4 to 6 weeks following the attack of quinsy, that patient should be subjected for tonsillectomy. Now the range is 4 to 6. If there is multiple choice question and there they ask you that what is the duration of our interval tonsillectomy, or after how many weeks of acute attack of quinsy the patient should be subjected for tonsillectomy, then the answer will be 4 weeks. And there are criteria for this interval tonsillectomy as well. One criteria is that if the patient is having a single attack of quinsy, and there is no previous history of recurrent sore throat or recurrent tonsillitis, that patient should not be subjected for tonsillectomy. Rather, that patient should remain under observation. But if a patient is having quinsy and there is previous history of recurrent tonsillitis, then that patient should be subjected for interval tonsillectomy after 4 weeks. And third criteria is that if a patient is having a second attack of quinsy with or without previous history of recurrent tonsillitis, that patient definitely should be subjected for interval tonsillectomy, that is after 4 weeks of attack of quinsy. So with that, we come to the end of today's session. You are requested to subscribe, like and share the channel, and thanks for watching.